one diabetic. Patients who have got many, many years of diabetes, and they're going to undergo a long operation, not an hour or two, but long operation. Then you need to give them calories, and you need to make sure that you give them insulin as well. So the GPI infusion, as we have all heard about, 10% dextrose with 15 units of insulin, rapid acting, with 10 millimoles of potassium chloride. You run it for 100 minutes per hour. And then you check somebody's blood sugar every 2 hours, and then depending upon what it suggests, if the sugars are normal, that's good, that's how you want to continue it. If your sugars are high, you need to, instead of giving 10, 15 units of insulin, you increase it to 20 units. And if your sugars are low, then instead of 15 units of insulin, you want to give 10 units of insulin. So this is essentially what I would do for long surgeries. If the surgery is only for 1 or 2 hours, I don't go to this dictum of GPI. Okay, you just can manage that after they have the surgery when they come back home or come back to the ward with intravenous fluid and insulin as required. What about insulin through subcutaneous route? Major surgery, following which they go back to the ICU or a high dependency unit, you generally wouldn't give people subcutaneous route insulin, particularly if you're hemodynamically unstable. But if they're hemodynamically stable, you could perhaps give them subcutaneous insulin. But you would avoid it for unpredictable absorption. Okay? And a sliding scale insulin dose adjustment is not recommended for now. All the ADA guidelines, the IDF guidelines, the International Diabetes Federation guidelines, all seem to shift away from sliding scale into subcutaneously. That is because we seem to be chasing the hyperglycemia. So the event already happens and you're trying to control their blood sugars after that. That hyperglycemia per se is detrimental to patients. So most associations do not recommend using sliding scale insulin. What you would do, you would perhaps give them an estimated dose of insulin about 0.2 or 0.3 units of kilogram per day of insulin, and you basically split it between 3 or 4 injections, and then give them a basal dose of insulin as well. That's what you would normally do. But honestly speaking, if you ask me what do, I think I still stick to sliding scale insulin. Why? Because it basically frees me from the telecommunication, otherwise that I'll have to handle every hour. Okay? Because it's easier, the protocol already exists, and a nurse can handle it. Or the other options, what I mentioned, actually needs a doctor all the time. Okay? So we don't have that kind of protocols in place. So once I am sure or aware that in the last 24 hours, my patient has needed, say, 30 units of insulin, then it's easier for me to go to what I mentioned to you. I will split it into 4 different doses. So you do a basal bolus regimen. Okay? The IV fluid per se, Ringer lactate or 5% dextrose, if it is actually not required, please just don't give it. It's just easier. Okay, otherwise it becomes too difficult for the doctor looking after patients with diabetes to control their blood sugars. Urine testing for dose monitoring, we don't do it anymore. Don't guess test, don't try and give it accordingly. And continuous cardiac monitoring. Diabetes is a heart disease equivalent. So long surgeries, major surgeries, they do have cardiac monitoring in ICUs or HDUs. That's where they need to be. And if you're worried or you're told, think that the patient might be in ketosis, you need ABG monitoring and the treatment of ketosis per se. Emergency surgery, you may delay the operation for a few hours just to give you some semblance of metabolic normalcy in terms of blood sugar, in terms of volume depletion, in terms of sodium potassium balance, if you have the time. But what I would rightly say, do not worry about the high dose of insulin that is required. In patients with cardiac bypass, I did a few months stint at Rabindranath Tagore Hospital here. I have given patients with bypass surgery more than 500 units of insulin a day. Because that's what you need. Insulin does only one thing, lowers blood sugar. Okay? So if your sugars are high, in spite of giving somebody insulin, you just need to give them more insulin. And just make sure that the insulin is going into the body you have pumps which don't work, then it becomes a struggle. So just make sure that those pumps are rightly connected and they are getting the insulin there. And when you're giving very high insulin, you get worried about hypoglycemia, which is the bane of treatment of diabetes anyway. Okay? Otherwise, treating diabetes would have been easy. Treat them with insulin, sugars falls, but if it falls too much, you really run into problem, hypoglycemia. And if you are aware of the recent data about hypoglycemia and morbidity and mortality, a lot of recent data in the last 6-8 months, the advanced study, the ACCORD studies, all suggesting that if you're getting too frequent hypoglycemias, these patients actually have higher mortality rates. Okay? So hypoglycemia has some prognostic value in terms of morbidity and mortality. Let me touch upon some special situations where we actually have data. We have data on cesarean section. If the mother's blood sugar is less than 110 during delivery or surgery, the risk of hypoglycemia in the newborn is the least. If it is more than 120, your risk continues to increase. Okay? So that should be your target. A blood sugar of less than 110 or 110, less than 120 during surgery, during delivery. We have that data. With regards to cardiovascular surgery, open heart surgery, the Van den Berg's classic paper about 3 years ago, or 4 years ago now, showed that if your blood sugars are maintained at near normal, about 110 milligrams, your outcomes for patients with bypass surgery would actually be dramatic. Less renal failure, less blood transfusion, less morbidity, less neuropathy, lesser number of days in ICU, and less mortality. It also ended the paper by saying an intervention as simple as controlling blood sugar has provided such dramatic results that no other intervention in CABG has done for many, many years to come. But it's a struggle trying to keep somebody's blood sugar at 110. If you're trying to keep your patient's blood sugar at 110, you're very likely to get a lot of hypoglycemia. It will be really a struggle. Okay? But if you can manage to do that, that would be wonderful. And foot surgery. Why I put foot surgery here? Please, patients with diabetes and foot disease, a lot of them have anesthetic feet. They don't need anesthesia. Okay? Still, I find some of my patients are having epidurals and they are having their operations done. In Nottingham, we used to do some of those small little surgeries in our own hospital wards. Here in India, at least in my hospital, I struggle to convince. I try and tell my colleagues, they don't need anesthesia. You can do little procedures by the bedside. Okay, no sensation at all. So the bottom line, team care in the background of safety and simplicity. It's about surgery, yes. It's about the anesthetist. It's about the diabetologist. It's about the junior doctor. It's also about the nurse who knows how to give insulin correctly, how to treat the hypoglycemia correctly as well. Very important. It's a holistic outlook. Don't look at only blood sugar. Make sure that you're looking at the patient's heart, the kidney, and the foot, so that at the end of the surgery, he doesn't come out with some new problem. And with the advancement of comprehensive care and new paradigms, it has changed. Okay? We are managing to do much more complicated surgeries and looking after even elderly patients better. I'll finish by saying, great things are not always done by impulse, but by a series of small things brought together. And it's definitely very true for diabetes. Thank you for your patient hearing.
Thank you, Dr. Saha. You have just heard Dr. Saha speaking, giving a threadbare analysis of